Hello, everyone. Welcome to the second day of Devex's coverage of the World Health Assembly. I'm Vince Chadwick. I'm the Brussels correspondent for Devex. I'm joined today by Amruta Byatnal, who's our Asia Pacific editor. And it's always great to get the Devex family together around the world for these kind of events. So good to be with you, Amruta. The sessions we're having today are about vaccine equity. And I'm sure many of our listeners will be here eager to hear from the CEO of AstraZeneca, Pascal Soriot. And we've also got a panel coming up later with the health minister from Sierra Leone as well. So stay with us. There's a really interesting group of speakers. I'm looking forward to the final session on IP rights as well, a hot topic at the moment. And we've got the Pharmaceutical Manufacturers Association and a speaker, Alan Tahuan, who's probably known to many of our listeners as a fierce advocate for IP sharing, I suppose. So, Amruta, there's plenty to get into today. You might be known to some of our readers as one of the brains behind our checkup newsletter on global health, which recently started. And which is WHA exclusive this week. So I wanted to start by asking what we should expect from this week's edition.
That's right, Chris. Thank you. Happy to be here. So yeah, checkup this week is going to be all WHA. We're going to be talking about the decisions that are being made, including ones that are not being made at the World Health Assembly. Our reporters across the world, including you yourself, Vince, are covering the World Health Assembly, and we're really excited to bring you the insights, some analysis, breaking news from the Assembly as it progresses. I'm also excited that we'll have an exclusive interview with the director, the polio director at the World Health Organization, to talk about what it really means and what the pandemic has meant for polio eradication efforts and what it really will take to eradicate polio as we know it. So yeah, we're excited about it.
And our first speaker today is an interview you're doing with Heidi Larson. She's from the London School of Hygiene and Tropical Medicine. What are you hoping to get into with her?
Right. Vince, I feel like right now we find ourselves at this kind of peculiar stage of the pandemic where on the one hand, we're dealing with vaccine shortages, as we know. There's severe shortages across the world in many low and middle income countries. And on the other hand, we're also dealing with vaccine hesitancy and rumors and misinformation. And I'm so glad to be speaking with Heidi today because there's no one else who knows rumors and the way they work and how to navigate them better than her. So yeah, I'm sort of hoping to explore, what she has learned in this pandemic about rumors themselves and how she sort of, works with government leaders and organizations across the world in kind of trying to dispel some of these myths, these rumors, and really bring information in front of the people.
It's an interesting time to be having these conversations with the news coming in today that South Sudan has also joined the list of countries who haven't been able to use their COVAX allocation. I wonder if that might come up. I mean, we've seen similar cases happening in DRC and Malawi, and those of us who like Devex who've been following the COVAX struggle to get the doses allocated, it can be horribly deflating to see that the last mile is not working as it should either. Will that feature at all in the conversations today?
Yeah, of course. I'm hoping to bring that up as well because, when we speak about vaccine preparedness and, the preparedness to deal with a crisis at this stage, we're not just talking about sort of, the hospitals and the, infrastructure that it takes to really deal with, the beginning of the crisis, but also the end of the crisis, as we may call it, the vaccine sort of preparedness. And that's something that we're seeing with countries like South Sudan. And I'm hoping to talk about, where does vaccine hesitancy sort of feature at that level too, and what it'll take to really get countries to sort of confront this issue and be better prepared next time.
We'll be listening. So without further ado, here it is.
To speak with Dr. Heidi Larson today. She's a professor of anthropology, risk and decision science, and the founding director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. She's been called the world's foremost rumor manager. And as we can imagine, these are busy times for someone with that profile. And I'm very happy that we have this opportunity to chat today. Thank you for joining us, Heidi.
Nice to be here. Go ahead.
Thank you. We have a lot to cover, so I'll jump right in. So, at the outset, I'm really curious to know, in your expansive career, you've dealt with rumors in all kinds of places, from war zones to Ebola-affected areas. What is so different about the rumors around COVID-19? And, what has your experience been in the last, say, like a year and 3 months?
Thanks. It's been quite a journey, I have to say. It's we have this background of, and you had mentioned polio. I mean, certainly in the context of polio, we were dealing with and still struggling in some of the hardest to reach areas with rumors, with distrust, and some of that is still there. And then, you have rumors on the other end of things, which is fears of who is manipulating them, what the motive is of all these vaccines. With COVID, it's been amazing, actually, in I think some assumptions in the public health community that this is has been such a bad pandemic from a health impact point of view that this will change people's minds if they were ever hesitant about vaccines. Well, it hasn't really. In fact, the groups and the questioning around vaccines and the some of the anti-sentiments have actually escalated in huge numbers. And what were conversations that were very much specific to vaccines are teaming up with other platforms against, particularly around anti-government control, but fears of technology, the 5G anxieties, the anxieties about the vaccine putting a chip in your arm. I mean, these are beyond vaccines. They're about other underlying anxieties. On the other hand, I have to say, since initially there was a bit of a desert when it came to vaccine confidence last year, because I think the focus was more on lockdowns, distancing, masking, because we didn't have a vaccine yet. But since the vaccines have come onto the landscape, there has been a lot of quite creative work going on around vaccine confidence building information. So it's kind of a good news, bittersweet story in the sense of some fantastic innovation and also some more serious rumor mongering than ever.
Right. And you started the Vaccine Confidence Project in 2010. And since then, you've been looking at data and studying almost 150 countries. So what has been your experience? And you were just alluding to it as well. What is your experience about trust building, and how does that sort of evolved over the years? And what is the specific importance of building that trust within communities right now?
Well, it's crucial, in short, but I think it's been an interesting evolution because I had been working in this area for 10 years before I launched the Vaccine Confidence Project in my role with UNICEF around launching Gavi and the introduction of new vaccines. It's taken the public health community initially from a global level was historically more central down, spread the information out. And, over the years, recognized the importance of locally tailored measures. But now with the advent of social media, we need to be constantly going micro, macro, micro, macro, because on the one hand, the trust relations at a very local level are absolutely crucial. On the other hand, we're in an environment now that you can think you have a reasonably trusting community around vaccines, and they get like a disinformation bomb that lands and totally can turn it around. So we need, on the one hand, our radar out there, on the other hand, trust building at different levels.
Right. And what do you see as the role of social media, both in sort of, spreading some of these rumors, but in also kind of educating people and really trying to get the information out there?
Well, I think discouraging people from, what are we saying now? Think before you share. But it's not always so easy to know if you're not reading up on all these different issues. It's not always easy to know what's true and what's not. And so one of the things is to try to build a more kind of critical eyes on some of what's circulating and build some resilience around it, not just debunk the facts, but kind of get a consciousness that people don't share them as quickly before they know, which isn't easy. And I think what you had asked earlier about what's different about COVID, we are in such a hyper uncertain environment, and the science itself is evolving every day. So I think that makes it a particular challenge because we're working with limited information in an uncertain environment. So trying to build people's confidence when the information keeps changing has been quite a challenge.
Right. And how do you navigate the complex kind of conversations around dealing with vaccine confidence when it comes to communities that have sort of been disadvantaged in so many ways? So in a lot of ways, they sort of feel like they've never been able to trust the government. Where I am in India, rural areas still sort of, are not super confident about vaccines. They don't, government officials have been going in every day. And they set up these vaccine booths, but no one shows up. So, but, you can't really blame them because these are people who have historically felt sort of excluded from the system itself. So how, and I'm sure this is not just specific to India. So how do you deal with, really kind of building confidence within these communities?
Well, I think one of the most important things that we learned certainly in the polio eradication work is that people need to feel like you care about their overall well-being, and you're not just there to push one vaccine all the time. Because we heard a lot, why do you keep coming with that same vaccine? Our children are dying of measles. Look at the dirty water you walk through to get here. We have other needs. We don't trust why you keep pushing that one thing and you're not helping us stay alive more broadly. So I think in the context of COVID, it's really important to try to hear there's so many things that have happened with people. They've lost jobs, they've been separated from families for distancing reasons. There's been a lot of issues. Haven't been able to get health services. So I think it's important in any kind of vaccination outreach that we take that extra time to hear what the concerns and other felt needs are in the community and somehow put the vaccine in the context of that, getting through this together. So it doesn't feel, so there is a sense that, there is caring beyond this vaccine. It can only help. Some people have very deep issues with vaccines and the governments that deliver them, and that may not change their minds. But for many, that will certainly help.
Mm-hmm. Right. So there are disadvantaged groups, and then there are groups such as pregnant women. And, as we know, the vaccines haven't yet been tested as much as they should have on pregnant women. And that has sort of given rise to this sort of skepticism amongst pregnant women. How do you sort of deal with this dual challenge? And what is your message to people who are also kind of at the front lines and, who are hoping to get women enlisted?
Well, I think we have, and we've seen it recently with the news from India, from the high numbers of pregnant women who have really died from COVID. And we had already been seeing that COVID infection it took a disproportionate toll in serious illness and sometimes death with pregnant women who are more vulnerable. In the same way that women who are pregnant are more vulnerable to more serious consequences from flu, which is why flu vaccines are recommended for pregnant women. So I think we need to put the vaccination in the context of the alternative, which is quite serious, and certainly in this current India context, hugely vulnerable to COVID infection. So there has actually been quite a bit of observational work around vaccines given during pregnancy with the COVID vaccine. And it's, so far it's all seemed to be safe and effective and really important.
Mm-hmm. Right, that's really good to know. And then we don't have much time, but I'm hoping to, add in one more question. So, you've been speaking with governments at, sort of like a wide range of, socioeconomic backgrounds from India to Rwanda to Colombia. What is your message to these governments as they are hoping to sort of tackle this issue of vaccine hesitancy going forward? Is there a secret sauce, or does it have to be tailored, according to context?
Well, every sauce is different in each of these countries, so to speak, and even at a local level. So I think the important thing is to really understand what the issues are. I used to have a sign on my desk at UNICEF saying, you can't fix a problem you don't understand, or communication can't fix a problem you don't understand. So I think it's really important to listen and understand what the issues are, because in some settings, it might be very specific to a safety concern. In another, it's a bad experience with the local healthcare center. In another, they're worried that the vaccines don't work. So I think there's a whole mix of trust reasons, very specific reasons. And, in some cases, we had experience that people didn't want to get vaccinated by a man. They wanted to get vaccinated by a woman or someone local, that if there was a problem, they could find them, to follow up. So I think it's just really important to understand these dynamics and what's really driving the issues.
Right. And as you say, sort of, communication is key, localization is key. Is there one thing that you are looking forward to as, we sort of go into this next stage of the pandemic?
Well, I think I think there's been a lot of learning, a lot of opportunity here. I mean, in the history of vaccines, I don't know when publics have had so much exposure to how vaccines are made, to what it takes to make, discover them, the regulatory reasons. It's been in the news every day, all kinds of things about vaccines, which I think it's been a huge opportunity from an awareness point of view, and people way beyond the health system. This is not a health problem. This is a global problem at challenge at many levels right now. So we've had a huge opportunity for awareness. And I think that people will remember COVID in a big way. And I think it's a really critical opportunity for us in terms of vaccine confidence moving forward. If people feel like they were heard, they were treated well, and they could build a bit of trust in a time of crisis, really, that will stay with them. They'll remember that when you come around with the measles vaccine or whatever vaccine or other health intervention moving forward. So I think it's a real opportunity. If they don't feel well treated, if they feel dismissed or judged or excluded, that will be the thing they remember. So every day in the context of COVID, we have to be conscious that what we do now will be remembered.
Right. That's a great message. Thank you so much, Heidi. This has been such an honor speaking to you.
Thanks.
Thank you.
Welcome, everyone, back to our coverage of the World Health Assembly. I'm Raj Kumar, the President, Editor-in-Chief of Devex, and really honored to be joined by Pascal Soriot, who is the CEO of AstraZeneca. I think everybody knows you and knows AstraZeneca. You've been at the center of this effort to get a vaccine for the coronavirus pandemic for COVID-19 and get it out to everyone in the world. So maybe we could just start with that, Pascal, because I know everyone here at the World Health Assembly is asking this question. How is it going? How do you assess the overall global effort to get a vaccine in everyone's arm around the world?
Well, Raj, first of all, thank you for having me. It's really a pleasure to be here with you and talk to this World Assembly. I think overall as an industry, we're making very good progress. Collectively, we are covering the entire world, I will say. And in our case at AstraZeneca, we've been mostly covering Europe and the rest of the world, and in particular the low middle income countries. So far, we have actually released more than 400 million doses. And quite frankly, this number is 1 week old, so we are probably more around the 450 by now. And we have delivered those to 160 countries. And we are going very well. Some regions, of course, have more challenges than others. We have a global supply chain, and it's going very well in some parts of the world and more challenging in other parts. But overall, 400 million doses of vaccine is a huge effort. And in India, for instance, 90% of the vaccinations are taking place with our vaccine through our partner, Serum Institute.
What do you think can be done? Speaking of India, what do you think can be done? India is in such a crisis that they have said, understandably in some ways, we're holding back the AstraZeneca vaccine for use domestically. But of course, COVAX and many countries in low and middle income countries in Africa and elsewhere were depending on that vaccine supply. What can be done to help address this so that we don't end up with some countries heavily vaccinated and others waiting a year or longer?
Yes, it's a great question. Actually, the plan actually was that we would supply COVAX together with Serum Institute, and AstraZeneca, we have our own supply chain supplying COVAX, and then Serum Institute was also going to contribute. But nobody expected this surge in the pandemic in India. And as a result, and we can understand it, of course, as a result, the government of India decided to prioritize supply to Indian citizens. So we are not able to export out of India. Now, the good news is our vaccine is making a big difference in India. But of course, the not so good news is we are short in supply to COVAX and the other countries. So what we're trying to do is increase supply from elsewhere, but it's very difficult because our supply chains are very stretched already. What we are hoping is that some countries that are getting to a good level of vaccination of their populations are going to donate. And you've heard that the US government is talking about donating some of their doses of vaccines. The European community is also considering it. So we are hoping that a number of countries will be able to donate to bridge, because at some point India will be able to restart exporting, and our own supply chains around the world will start kicking in and ramping up. So it's a question of bridging between now and then. And of course, what people need is a vaccine today, and that creates a lot of challenges.
It does. And what are some of the blockers that you are most worried about? I know IP has been a big question, and whether if that were relaxed, would that actually help speed up the process? There's, of course, other issues like cold chain, health workforce, especially when you're thinking of low and middle income countries. There are examples of countries that had vaccines and were not able to actually deliver them. What are the main things you're focused on in terms of getting this vaccination rate up?
Well, IP is really not an issue in our case, because we decided up front that we would supply the vaccine at no profit. So, we're basically supplying at cost.
But isn't it an issue in terms of other manufacturing sites being able to take it up and produce it on their own?
Yeah, so you have the price and you have the capacity. It's a good question, Raj, and I was getting to it. So then the capacity question, we again tried our model is as close as it can get to the no IP model. We have 25 sites around the world. We're partnering with a large number of partners around the world, and we've we've trained them in the technology. We've done what is called a technology transfer. We really could not go beyond that. Our priority now has to be to improve productivity, output at each of those sites. We've had issues with yield, which is the number of doses of vaccines you get out of 1 liter of product in the bioreactors. And the key for us is to really increase the yield so we can get more out of a bioreactor. We could not increase the number of sites. First of all, we've really talked to all the large capacity manufacturers in the world. And secondly, even if there were new ones, we really would not have the capacity from a people viewpoint. We would not have the engineers to train them on the technology. Our engineers are working 24/7 on trying to improve the output, the yield, the productivity of the ongoing sites.
And what about some of the other blockers, in terms of health workforce, train people to deliver it, or cold chain? What are some of the other things you're thinking about and focused on?
This is a great question. In fact, in our case, really, we've had two issues. Cold chain is not an issue. It's been an issue. It's an issue for other vaccines, and those manufacturers are solving the problem in many places. The issue for us has been more a question of training the staff with our partners, because as you can imagine, you don't go from 0 to or a few 100 million doses of vaccines to billions. So many of our partners have had to recruit staff, and those staff have had to be trained, which is what we did last year. But making vaccines is complicated, and that has had an impact on the yields we get out of these bioreactors. So our focus has been to train people, make sure they understand the process better and better, and we're making progress. The yield is increasing. So it's been more a question of the staff, the recruitment, the training. And in some cases, mostly with Serum Institute, it has been about sourcing material and sourcing parts of equipment like filters that go into the production, and some of those coming from the US, and there was not enough. And again, our partner Serum Institute is working hard to solve this so they can further increase their capacity.
I mean, you famously stood up because of this emergency and created this new vaccine initiative. But AstraZeneca wasn't in this business before. Do you think this is a one-off? Will you see through this emergency and then that's it? Or is AstraZeneca going to become a player in the vaccine business?
We haven't decided this, Raj. I mean, as you can imagine, we are 100% focused on delivering the doses that people need around the world, in Europe, of course, but elsewhere in the world, the low middle-income countries, and also the upper middle-income countries. I mean, Brazil, we have a partnership with Fiocruz, and it's going very well. As I said, some regions are doing very well, and other regions are facing challenges. So our focus is really getting everybody up and running, improving yields, training staff, working very closely with our partners. And we'll turn our attention to the next steps when we have indeed delivered this vaccine to as many people as possible around the world.
Yeah, I ask you that in part, Pascal, because a big conversation point at this year's World Health Assembly is the future of the vaccine supply chain delivery system. There are many people calling for manufacturing to move, for example, to countries in continental Africa. How do you see the broader questions? You talked about IP not being a blocker for today's emergency right now, but when you think about the future of this industry and the way vaccines are manufactured and developed, what do you see going forward?
Well, I think that what this crisis has shown is that vaccines are not only a scientific challenge, they're mostly an industrial challenge. If you think about it, a year ago, I mean, I'm sure you'll remember, everybody was talking about 120, 130 vaccines, in development in various places. And today there's 4, 5, 6 maximum. And of course, some haven't worked for scientific reasons, but mostly the issue has been capacity, manufacturing, scale, right? So I think for the future, it's really a question of scale. And what we've tried to do is establish supply chains on a regional basis. So we have one in Brazil with Fiocruz, as I mentioned. We have one in Latin America. We have one in South Asia. We have one in India, of course. We have one in China, one in Japan, one in Russia, Europe, US. So we've really tried to regionalize those supply chains to be able to cater to the needs of those countries on a regional basis. I think the question for the future is really how do we set up, we as a society, countries, regions, how do they set up capacity that can be tapped into very quickly? And easy to say, not so easy to do, right? Because of course, we all hope we won't have another pandemic like this for a long time. And so if you don't have one for a long time, then in the meantime, what do we do with this idle capacity that someone has to pay for? And so this is one of the things that I guess governments and organizations around the world will have to think through. how do we maintain a capacity that can be tapped into very quickly to scale up manufacturing?
I think part of the conversation is whether that capacity can be used for routine vaccinations, and like the typical vaccines a child gets when they're born, and then can also be repurposed in an emergency. I don't know if you think that's practical based on what you've seen.
You know, the big difference is, if you think about it in terms of the current vaccines, we're talking about hundreds of millions of doses a year. And here with a pandemic like COVID, we're talking about billions. So if you try to make, I don't know, for the lack of a better word, current vaccines or common vaccines in this large capacity, you will make those vaccines very expensive. And of course, vaccines like those you supply to the low middle income countries, they have to be low-cost vaccines. And to be low-cost, you have to maximize the utilization of your capacity. So there's a tension between keeping the current vaccines at a low price by maximizing the use of the capacity you have versus keeping capacity ready to be used for a pandemic. At the end of the day, it's a question of money, right? I mean, nothing more, right? And but it is an issue that has to be tackled.
Yeah, money and who pays for it. I guess maybe, you know, it's so interesting to hear your thoughts on this. You've had an incredible, busy, intense year right at the center of this crisis. What are some of the lessons that you've learned from it when you look ahead now and you think about where we want to go in terms of strengthening health systems? What are some of the big lessons you take away from this pandemic, which we're still very much in, but the point that we're at now?
Yeah, I mean, I think first of all, as it relates to vaccine, as I said, capacity, manufacturing capacity, everybody's focused on science. And of course, the mRNA vaccines are a new technology that have emerged. So science is important, there's no question. But it's really a question of industrial capacity. So that's one issue. And in terms of healthcare system as a whole, I think, again, we need to think a little bit about redundant capacity in some cases, but mostly we need to think about flexibility and agility of those systems and the use of digital, so that you more and more look at how can you diagnose and treat patients outside of the hospitals, reduce the visits to hospitals so you can actually have better use of the capacity that you have in the hospitals. And I think digital here can really play a big role in the future to treat a variety of diseases and then enable the treatment of those people outside the hospital. In fact, one of the big tragedy in this COVID crisis is, of course, COVID and the deaths related to COVID itself, but then they have an indirect impact of COVID on other diseases. We've seen a substantial drop of 20-30% in the diagnosis of cancers. We've seen a drop in the number of heart attacks being treated in hospitals. Why? Because people were worried about going to hospitals, and the system itself was not able to process people who had symptoms and required a scan or something that would enable diagnosis of cancer. So we need to find new ways to manage those people and those cases better in the future in case of a pandemic.
It's a great point. When you think of the lockdowns and all the economic effects that it had on people, their livelihood, so much of it was to protect the limited capacity in hospitals. If you can get that kind of healthcare treatment to be digital, it creates more flexibility and maybe really enhances the opportunity to get through a pandemic without all of these negative side effects. Pascal Soriot, it's been such an honor to get time with you today and to hear your voice as we cover the World Health Assembly and think about these big picture questions for the future. Thank you so much for what you and your colleagues are doing at AstraZeneca, and thanks for your time.
Thank you, Raj.
Thank you to everyone for joining us for this panel where we are focusing on the experiences of African nations in rolling out COVID-19 vaccines. Many countries across the African continent have leaned heavily on free doses from the COVAX facility, which are mostly the Oxford AstraZeneca vaccines, as well as several countries receiving doses of the Pfizer vaccine. The African Union has also secured Johnson & Johnson doses for countries to purchase, will be available starting in August, September, and countries have also made their own arrangements. but there has been mixed success in rollouts. Some countries were able to very effectively roll out doses they've received, while others have struggled. Some of the big challenges included inadequate funding for rollouts, quickly approaching expiry dates, as well as uptake among the populations. And with the COVID-19 crisis in India, the Indian government has restricted export of vaccines, which has cut off COVAX's supply to the vaccines produced by the Serum Institute of India, leaving many African nations unsure when their next shipment will come. To talk through all of this, we have Dr. Mahigo, who is the Immunization and Vaccine Development Program Coordinator at the World Health Organization's Regional Office for Africa. We also have Honorable Minister of Health for Sierra Leone, Dr. Austin Demby, Honorable Minister of Health for Ghana, Dr. Kwaku Agyemang-Manu, Dr. Saban Nsanzimana, the Director General of the Rwanda Biomedical Center, and Anstes Agnew, who is the Head of Health Systems at the Tony Blair Institute for Global Change. And my name is Sarah Jervine. I'm a global health reporter here at Devex. For all of our listeners, if you can please use the chat feature if you want to introduce yourself, and the Q&A function to ask questions to our panelists. Closed captions can also be enabled by clicking below. So to begin the conversation, Dr. Saban, Rwanda has been praised for its rapid rollout of vaccines, and your team began rolling out vaccines across the country only 2 days after receiving doses. How were you able to do this?
Thank you, Sarah. Thank you, everyone, great panelists, ministers, colleagues, and all who are following up. So this is a very interesting question. When we talk about vaccines rollout, and I would say that the first phase of vaccines, because as we speak now, there's no single dose of vaccine left over in Rwanda. We're just waiting to have the next opportunity to give this life-saving tool in public health, which is actually vaccine comes as number one. So the rapid rollout of vaccination in Rwanda has been guided by a few principles. First, we had to understand that the vaccines are coming here to alleviate a burden of a disease that if we don't do something, we will get more and more cost to incur. It's actually going to affect not only our health, but also our economies. So whatever doses is coming should not be kept into the storage. That was the principle number one. The principle number two is that we are not creating a new vaccine supply chain system. We already have a national vaccination program that existed for more than 2 decades that has been rolling out and implementing vaccines that are probably even more complex for children and for special targeted groups that are hard to reach. That this one was even quite easier to roll out if you think of these are adults, people easily to find out. Number three, as a principle for us for rapid rollout, was to engage all sectors, all programs, or everyone who was involved in COVID response had to take this as an additional opportunity to reduce the spread of the disease. See, the local government, the Ministry of Health, the security organs, the partners, all the sectors, including private sector and the communities, were part of a committee that was coordinating on a daily basis. So speed, coordination, and understanding that this is a firefighting mode. So if we need to fight a fire, you don't want to lose even 1 minute, because the damages will be much more important. So that is how when the vaccines arrived on March 3rd, just 48 hours after we had already started to vaccinate across the country, because of what I said, but also because we wanted to see how the demand of the community was quite high. We didn't want to lose that momentum, given the time we've waited for these vaccines. understanding that people outside there waiting, for us to wait more time would create some kind of a gap between our health systems and the community, and yet the trust and the relationship we've built is all about how can we save even one single life timely. And the last aspect was that we should not be constrained by finances to roll out vaccines, because the losses, if we don't roll out the vaccines, are more costly. And we had costed our plan. We had made a plan earlier before. We had purchased vaccine storage, deep freezers for all type of vaccines. But there was still a gap in terms of resources and funding. But that, we say, this should not be something to block us to move forward. Because if you wait, then the cost will be even double and triple. So in brief, this is how we were thinking, and this is how, when we received the 290,000 doses of AstraZeneca and 100,000 doses of Pfizer, we quickly distributed. And after 2 weeks, we had almost finished all the doses. And now we're just waiting. It's another phase that, as a doctor, as someone in the health sector, don't want to be. It's uncomfortable when you think that there are tools somewhere and there's people somewhere and there is a disease that is around and you can't connect the three things together. It's really uncomfortable, and we're working with our partners, working hard to make sure we get more vaccines and we go into our second phase. Thank you.
Okay. Thank you. And Anstes, you're also based in Rwanda. Could you talk a bit about how smart data management played into Rwanda's vaccine rollout?
Thanks, and thanks to the Director General for his point. I think this point about not wanting to waste 1 minute is so critical. And while data had long played a part in Rwanda's health system, Rwanda did everything possible to shorten that learning curve and have data at the ready to move quickly. And data really played a role at every stage of the rollout. There were digital systems in place when vaccines hit the tarmac to track the cold storage and to get vaccinations into fridges, but quickly, really the same day, out to health facilities, and to track exactly how many doses had gone to health facilities across the country of AstraZeneca and Pfizer. The second then was having data capture. So as citizens arrived for their jabs, all of their data was captured digitally in a centralized system. This both meant that when citizens arrived back for second doses, there was clear record keeping and a quick way to identify exactly who needed to come back and when, but so that decision makers could make the choices about allocations of doses. So because each health center had prioritized having a data manager in place, having a tablet in place, it meant that as soon as healthcare workers at a health facility had been vaccinated, the district could call up local community health workers next, and then move on to teachers and other essential workers. And that data was there in real time about doses available. And it was data that had been collected well ahead of the vaccination campaign, so that there was really this ability to move quickly. And I think another really important piece about that data storage and centralization for COVID-19, it's as much about decision makers having at their fingertips the data on rollout to understand where scarce supplies are going, but also so that citizens can access their records, so that community health workers can follow up, so there's no loss to follow-up. In Rwanda, it meant that community health workers could be proactively calling citizens and alerting them to changes in the schedule when, for example, AstraZeneca was delayed. And it means that that data is there to facilitate global reopening, both for the healthcare system and the wider economy.
Thank you for that. Now turning to Dr. Mahigo, could you talk a little bit about kind of access problems when it relates to accessing vaccines across the African continent, and what options countries might have when it comes to accessing doses, second doses, to complete immunizations?
Yeah, thank you, Sarah, and good afternoon. And I'm really glad to join this very good panel with such high profile colleagues. Let me first start by saying that when we looked at the access, really, and particularly we are talking about almost 5 to 6 months since we have started to see the global rollout of COVID-19 vaccines. Africa did prepare itself quite very well. Most of the countries, before even the vaccine started to be rolling out, and we've heard a very good example from Rwanda, had plans in place, had very clear targets to reach population. Objectives were there, and we have seen when the vaccine landed in the countries, immediately activity started. But the supply didn't really follow the ambitions that country had. And as of today, for instance, if you look at the data that we have at WHO, it's quite concerning because so far, if we looked at the global level, close to 1.5 billion doses of COVID-19 vaccine have been administered, compared to only 28 million doses in Africa. So on average, that gives you around 2 doses per 100 people in Africa, compared to close to 22 to 23 doses per 100 people globally. So that really gap is unfortunately going wider, as many countries are waiting additional doses, as we have heard from Dr. Sabin. One of the reasons of this gap has been, of course, the dependence that COVAX facility have had so far with the Serum Institute of India. Nobody could have predict what went on in India, which had to almost suspend the delivery of the vaccines. If we looked at what was planned to arrive in March, April, and May, we are talking about 160 million doses that was in the pipeline that unfortunately didn't arrive in the country. I think that's a critical access, a critical issue in terms of supply. Our countries, even those countries that are doing quite very well, when we are looking at the overall coverage compared to the general population, they are still very low. I think the data from Rwanda, from Ghana, showing that there are less than 3 doses per 100 population globally. Despite the eagerness, despite the preparation that went on in those countries, Sierra Leone, we heard as well from the Honorable Minister, the supply are not following what the country are doing. And I think this is why at WHO we've been quite very concerned, and we really launched an appeal to the international community to make sure that a country in Africa can be supported to get the doses that they need to protect not only frontline workers, but also the people who are more at risk of getting the disease, dying from the disease, and ultimately have supplies that will help countries in Africa also to see the end of the tunnel and to start to reopen widely the economy on that. So very good progress last week during the Global Health Summit with the pledging of additional doses by high-income countries. But what we need for the moment, it's really to see those pledges being materialized in concrete delivery in countries, so that the second doses that are due already in many places can start happening. So just to give you a number, we need urgently at least 20 million doses of AstraZeneca to make sure that the countries that have started vaccination can at least provide the second doses to the people who have received the first dose. So to not break that confidence, that trust that has been established by government with their population in delivering these vaccines, urgent action are really needed to make sure that a country can receive as soon as possible the vaccine. And we are working hard with not only the high-income country, but also to diversify a vaccine portfolio so that we're not depending on one product only. And if there is a problem, everything gets stopped.
Thank you, Doctor. And now if I could turn to Honorable Minister Demby. You, from what I understand, Sierra Leone received its first doses in early March. What have your experiences been like in rolling out the vaccines? What strategies have been effective, and what challenges have you faced?
So thank you very much, Sarah. I think experience is derived or is informed by what happened with Ebola in Sierra Leone. As you know, Sierra Leone was one of the countries that was impacted the most, and there are lots of lessons learned from that. And so when we heard of COVID-19, the mitigation measures, except for the mask, were ingrained in people. And so it's not surprising that Sierra Leone was one of the last countries in Africa that had COVID-19 introduced, because I think we had all of these very effective mitigation measures. One of the challenges that we've had with vaccinations is just the fact that people are just really quite concerned that these are new diseases that they've never heard of before, and all of a sudden you're asking them to have vaccinations. And I remember in the Ebola case, people were saying they're actually inoculating us with Ebola virus, and that's why we're dying. So there's this real fear, deep fear in people in Sierra Leone, and deep skepticism as well. And I think we had to overcome that. And one of the key lessons we learned from Ebola is being a good listener. Don't come in with solutions that you think are going to work without really listening to people, because a lot of their concerns were deep concerns that if you address those concerns, you could turn the table around and we have them as strong allies going forward. In our case in Sierra Leone, we realized that people were concerned about the vaccines, and they said, if these vaccines are so good, why don't the president be the first person to be vaccinated? And so what we did was the president and all of the cabinet members, all of the leaders in government, all of the judiciary, everybody had a major launch event where everybody was vaccinated in public, and we all walked away with a biometric card that shows that you've indeed been vaccinated. The second issue that they had was, we're not sure about these vaccines. Are people going to be glowing in the dark? Are they going to be dying? Are they going to have all kinds of complications? And what we did was we reassured them that these are new products. The evidence and data that's available shows that the adverse events are very, very rare events. But what we'll do is we'll put in place systems of active pharmacovigilance for anybody that's been vaccinated, and we'll monitor and track them and make sure that if there are any adverse events that we're able to deal with it. And so with the combination of the confidence building by the president and the cabinet, the combination of that with the pharmacovigilance effort, and the fact that we took time to explain the science in very, very layperson's terms. Now, we have a situation where people are very, very interested in being vaccinated now. We had vaccines from China. China gave us Sinopharm vaccines at 200,000 doses. COVAX gave us about 98,000 doses. And so that's another complication. What do I take, the Chinese vaccine or the AstraZeneca vaccine? We had to explain the science behind all of that and get people to a comfort level. We're at the point now where people are very interested, they're very excited, they're all bringing their relatives in to be vaccinated. We deliberately focused on high-risk populations at this point, and we're willing to expand, constantly expand the eligibility criteria. But we're now worried because I think when we started, we were assured that we'll have the second dose, the second batch of the COVAX vaccines by early May. And we were promised 500,000 doses. And with that kind of resupply, we could really expand as much as we want. But then we found out that what was going on in India, there were doubts now about the availability of the resupply. and there's potential gap in vaccines availability. So we have a moral dilemma now. Do we use up all of what we have and have nothing when potential wave of the India-like situation unfolds in our hands? Or should we merely target and continue to utilize our vaccines at the highest risk populations until we're assured of the resupply component? So that's our moral dilemma we have now. High uptake, high interest, but we're worried that we may not be able to resupply. And one of the biggest concerns we have is if we have an interruption in our supplies after we've raised so much demand, so much interest, it'll be very, very difficult to re-engage later on. So we're asking Dr. Mariko and our colleagues to really do everything you can to make sure we have the resupply. We'll be able to uptake all of what's given to us. Right now, we're at 1% vaccination of our population. We'd like to up that tremendously, and it's going to be very easy to do using the existing systems, but we want to be assured of the resupply. Over.
Thank you. And Honorable Minister Agyemang-Manu, what has been your experience with rolling out vaccines in Ghana? And what sort of challenges have you faced? What strategies have been effective for you? I think you're on mute, Honorable Minister.
Yes, I'm unmuted myself. Experiences will not be very much different from what Sierra Leone is talking about. We had two plans prior to the allocation, even the allocation of vaccines from COVAX. We initially did our vaccine plan, and then later we did a deployment plan. And we were the first amongst the whole globe, the whole world, that got the COVAX vaccines, over 600,000 doses. We had planned to deploy with our traditional immunization structure. Our system was very robust. You know, Ghana is doing about 95% DPT3 coverage. So our system was quite robust. All we did was within a day or 3 days, did refresher training for our vaccinators and added on a few more. We had a strategy. We had 2 cities where we had this pandemic hit most. The spread was very fast in the largest city, Accra, and the second largest city, Kumasi. So though we picked different groupings as part of our plan, the first highest risk, including health workers, we even concentrated in these 2 cities first. And we selected 43 districts from these 2 regions and just 1 district from the next alliance region to the Greater Accra, the central region. So we started our vaccination with health workers, the legislature, the executive, the judiciary. We needed to use high-flying civil servants and public officials because of our fear for hesitancy. We did some good interviews with people, and they were talking about they want the big men to do first. So the big men went in first. Our president did his first vaccination. I did the second day. The vice president did the first day. And so the Supreme Court judges and all that. And when this exercise was completed, we had a continuous plan. So our rollout was very smooth. Now, into about the 5th day, we had gone that much far. So people outside the 43 districts, especially health workers who had been identified to be in the first category of cohort of population, started agitating outside the areas that we actually zoomed in first. So we had to split our tackles to do health workers, people with underlying conditions, the elderly above 60 years, you know. So we moved on. Teachers above 50 years were also included because we had open schools. So within the first 2 weeks, we had virtually completed more than 50% of the vaccines that were given us. And we didn't want to wait because we had assurances and indications. We were working together with UNICEF in country to be receiving allocations that have been given us from COVAX. Unfortunately, India hit, And it's like we got information that our allocation, the second allocation, 410,000, wouldn't arrive in March. Then they have given us within the first quarter to May, we will get about 2 million doses. So later in course of the period, when we had virtually exhausted all we had, we're not going to get nothing. We waited, May came, and then that is it. But we got some little extras from somewhere. MTN had some doses that were not being used in South Africa on the African Medicine Supply Platform. This was distributed to some African countries. Ghana benefited. So we added on to 600,000 through that window. So after that, we had done close to about 966,000 doses had been administered in the first phase. Then we were waiting for a location. We couldn't get deliveries. And then those who started 1st March came close to 8 weeks and were moving close to 12 weeks. But from science and data, we decided to hold on, but we were not panicking until we started our second dose of 350,000. This was pulled from somewhere else through the efforts of WHO AFRO. I hear Congo wasn't administering very fast. So when they thought that it will expire,
I think we might be frozen. Yeah, I think the Honorable Minister is frozen. We'll come back to him to finish up. Dr. Saban, I wanted to ask you, so Rwanda was one of the few countries that received the Pfizer doses in the first allocation of COVAX. Did Rwanda have the cold chain infrastructure in place in advance to this, or what were kind of the steps that it took to receive these doses?
Yeah, we had these deep freezers even before the vaccine arrived, but we had planned to increase the number of deep freezers to augment our storage capacity for these vaccines when we were already following up on the conditions for Pfizer, Moderna vaccines requirements. So we had, in the meantime, I think it was almost at the phase 3 of the trial towards the end. So we purchased additional deep freezers because we knew that this is coming. It's going to be a key condition for being able to manage these vaccines.
Okay, thank you. The Honorable Minister from Ghana is back. So if you would be able to finish up with your statement, sir. Sorry, I think you're on mute.
yes. Like I was saying, by Friday, we'll have exhausted the extra we got from the efforts of WHO AFRO. And we are waiting desperately to try to see where we can get extra vaccines from. We are making all efforts even to procure ourselves from sources that we thought we could get. We were pushed out of anticipation that we may lose our clientele who had actually washed away vaccine hesitancy and tried to take vaccines from even Russia. But all our efforts have also proved even futile. We can't get deliveries. They keep on giving us different delivery dates into August and September and July and all that. We have signed on to, how do I call it, self-procuring from COVAX, but of trying to assist countries that want to buy themselves. We have signed on to that. We have signed on and even put some money in advance for African Medicine Supply Platform, the AU window, for Johnson & Johnson, that will come in August and September and beyond, even 2021. So we are making efforts to even procure ourselves with the support of the World Bank, but we can't get nothing from nowhere. And that's our predicament. Now we are pleading with people who have got the first one, waiting for the second dose to panic. We are making efforts to get vaccines with assurances from COVAX and Gavi and everywhere, based on this strategy of dose sharing. The announcements from UK and the US, President Biden promising to release 80 million in 6 weeks. We believe that if that goes through the COVAX window, some of us that are desperate to get vaccines for even administering second doses may get them before we even think of expanding to do first doses for other cohorts of population. So that is where we are. Our system is quite robust, actually. And if we get vaccines, we wouldn't delay at all.
Okay, thank you, Minister. Dr. Mihigo, you've talked a bit about how COVAX is trying to diversify its portfolio. Can you talk a bit about that? And then also, what are some of the key mistakes that countries made in the first round of vaccine allocations that you hope aren't repeated when countries get new allocations of vaccines?
Yeah, thank you. Thank you, Sarah, for this question. Maybe before responding that very quickly, I think we heard a very quite strong message from the honorable ministers in Ghana, Sierra Leone, but also the Director General of Rwanda Biomedical Center. Countries are eager to roll out the vaccine if they've got supply. I think they need definitely some predictability in terms of the supply pipeline to maintain the momentum. We despite everything that was said at the beginning, I think that countries in this region did prepare very well the arrival of the vaccine. Now, with the pipeline, as you have asked, we have seen the situation in India, which was not predictable at all, and which has a very, unfortunately, negative impact in the supply situation for COVAX facility. Right at the beginning, the objective of the COVAX was really to diversify as much as we can the vaccine portfolio so that we can offer a much more broad range of products to the member states so that they can make their own informed decision. Luckily, we have now, out of the two newly approved vaccine for emergency use authorization, the COVAX has struck concrete deals now with Moderna for 500 million additional doses, which unfortunately we're not going to be ready right now. We are going to receive a small quantity, around 30 million, the fourth quarter and the remaining next year, but also a very good prospect with Johnson & Johnson, probably starting in July. We hope that these efforts are going also to be complemented by the what the African Union platform, the AVAT, is doing also through Johnson & Johnson to increase, to augment the capacity of country to deliver these vaccines. Now, on your last point on what are the mistakes that country did, I think we saw that there were clearly in a few countries a gap between the plans that were developed, very good plan on paper, and the micro plan that were meant to deploy the vaccine. I think most of the country now are trying to address that gap from the micro planning to really meet from the macro planning to micro planning so that they can target very clearly their intervention. Secondly, though we heard Rwanda clearly saying that financial resources at the beginning, though not necessarily sufficient, was not necessarily a big bottleneck for them. But unfortunately, we saw in many countries that implementation costs to facilitate the rollout of the vaccines were not there. So we're working with the World Bank, working with other partners through the COVAX to not only improve the supply, but also to improve the financial assistance to the country. And then finally, we heard about the vaccine acceptance or uptake in the country. So there's been a lot of challenges in terms of, I don't know if we can call it hesitancy, but also sometimes refusal of the vaccine So we need absolutely to invest a lot of effort in that area to make sure that we create that trust, confidence of the population to the vaccines once they become available.
Thank you. And that was the perfect way to round off this conversation. We've unfortunately run out of time, but it's been fascinating to get all of these insights into how vaccine rollouts are playing out across different countries on the African continent. So I want to thank you so much to all of our speakers for joining us, and thank you to everyone who tuned in.
Hi, everyone. Welcome to Devex at the World Health Assembly. Today we're here to talk about a much contentious issue of IP waivers for the COVID-19 vaccine. And I have with me Thomas Cuny, who is the Director General of the International Federation of Pharmaceutical Manufacturers and Associations, and Ellen Duhuin, who is a lawyer and public health advocate with over 30 years of experience working on pharmaceutical and intellectual property policies. Now, I understand that the two of you come to this issue with slightly different perspectives, so it would be great to hear both your points of view and sort of try to understand what is the future of the IP waiver and what that means for the COVID-19 vaccine going forward. So Ellen, would you like to start? Would you like to begin by telling us what the importance is of the US, reversing its stand on the IP waiver and really coming out in support of it, and what it means for other countries and other organizations as we are now looking at, the pandemic that is still kind of surging the world over?
Yes, well, first of all, thank you for inviting me to take part in this in this discussion, which is indeed a very important one, and we've been involved in this for quite a while, because while the TRIPS waiver was proposed in early October last year by India and South Africa, those were the countries that put the proposal on the table at the TRIPS Council at the World Trade Organization, which is the body that discusses issues of intellectual property. And the idea of the TRIPS waiver is that it would allow countries to suspend the protection of intellectual property on products that are necessary to respond to the COVID-19 pandemic for the duration of the pandemic. So it's quite it's a limited proposal. I want to stress that, because I sometimes hear people talk about, the TRIPS waiver, we're going to suspend intellectual property forever and for everything, but it is really quite narrow and focused on issues related to the pandemic. But what is important, it's important to actually go back a little bit further in the history of last year, because earlier that year, almost more than a year ago, the World Health Organization had launched the COVID-19 Technology Access Pool, which was is a voluntary mechanism. It offers a platform to those who hold intellectual property, including know-how, data, knowledge, technology that is necessary to, for example, produce vaccines and other products, to share those on that platform voluntarily. But that didn't get a very good response. That pool remains empty until today. And that is important background to understand why developing countries are saying we actually need more forceful measures. And that is how the issue was put on the agenda of the World Trade Organization's TRIPS Council. Now, you fairly quickly saw the sort of traditional divide of developing countries supporting South Africa and India, and the high-income countries saying no to the TRIPS waiver and raising lots of questions about it. And fairly recently, in a surprise move, the Biden administration has come out in support of a TRIPS waiver for vaccines, which surprised everyone, I think, although President Biden in his election campaign had promised that he would ensure that IP would not stand in the way of worldwide access to vaccines. So it sort of, he was sort of fulfilling his campaign promises. Now, what will ultimately happen will depend on the negotiations in the TRIPS Council, because the United States, as important as it is one country, and it can make a proposal, but the ultimate agreement will have to be reached in the TRIPS Council. The countries remain divided. The European continent is divided. There is not an EU position yet, as far as I know, and we've seen European countries respond very, very differently. It will be important to see what they are going to do. But a much bigger question is, and I'm sure it's one you will also want to discuss, and it's probably also one that Thomas wants to discuss, is what can the TRIPS waiver deliver and what can it not deliver, and what else needs to happen. But in short, the message from the Biden administration is very, very clear. They're saying it cannot be business as usual. Something will need to give. And the double no position that we've seen, rejecting the COVID-19 technology access pool, the voluntary mechanism, and rejecting the TRIPS waiver or action at the WTO, those are not positions that remain tenable in the current situation.
Right. Thank you so much for that, Ellen. Thomas, coming to you now, I'll pose the question that Ellen has raised. What will the waiver do? And, does the US's position put pressure on other countries now? And where do you think, this movement of sorts is going next?
I hope you don't mind, but we really need to put this in context, because the context is the world has been confronted with SARS-CoV-2, COVID-19, with the biggest public health crisis since 1918-19, when we had the Spanish flu. And when I look at where are we, 15 months after the pandemic was declared, I think one first has to acknowledge we have seen an amazing victory and triumph of science. And when we look at where does this come from, when I discussed the challenges in June, July last year, I can tell you most people I asked were expecting that we might have vaccines by maybe early summer 21. Now, we are not yet in early summer 21, but we have seen vaccine rollouts since early December in the US and the UK, and actually since the end of January in other parts of the world. And not one vaccine, but several safe and much more effective. You also have to bear in mind that originally the objective was a vaccine with 50% plus effectiveness. We have had 2 mRNA vaccines with 90% plus effectiveness. Therefore, we have seen a triumph of science. And why have we seen this? Because everyone, academia, biotech companies, big pharma, industrialized developing countries, really engaged in working, developing safe and effective vaccines, and already more than a year ago, started partnerships, started scale up at risk. We have seen, for example, 3 of the top 4 vaccine manufacturers failing with their projects. But each and every one of them came in and offered partnerships with fill and finish, with active substance. Therefore, we have seen something. Ellen was talking about this CTAP concept. Now, what we saw is this is happening. Technology transfer on a large scale. We have seen more than 280 contracts signed between big pharma and big pharma, biotech and big pharma, but also industrialized and developing country manufacturers. And more than 200 of them include technology transfer. Why do I say that in the context of the waiver discussion? Because it was done with really the common objective. We need to vaccinate the world. We do need the 10 billion plus doses to bring the COVID-19 vaccines to all who need them, who want them, and hopefully in most countries for free, as it is in my country. And we are on track of achieving that. But by and large, the challenges and complexity of vaccine manufacturing were hugely underestimated and still are. And by and large, the industry has exactly reacted as you would hope. Unprecedented partnership, helping out with know-how transfer, joint training of skilled workers, and we are in there. The waiver as such wouldn't do anything to address the bottlenecks which we have, because the bottlenecks are different, but the waiver would question the very legal framework which encouraged and gave companies the trust to sign contracts with developing country vaccine manufacturers, to engage with other big pharma companies, to engage with biotech. And we really shouldn't lose sight of sight. The objective is to get the vaccines to the people who need them. And there we are confronted with an unacceptable situation now. We see 18-year-old healthy kids in, for example, the US vaccinated at a time when, because of the crisis in India, almost no vaccines are reaching Africa. That is something which we need to address as a matter of urgency immediately. And that's where we need to have more solidarity from the rich countries with the poor.
Right. Thomas, you talk about solidarity and you talk about, vaccine inequity in a way, right? I mean, we can see that most of the US and the Western world almost seems to be going back to normal now, whereas where I am in India, we're still in lockdown. Cases are increasing every day. So if not the IP waiver, what do you see as a solution to this issue of vaccine inequity? What do we need to do? And who needs to get behind these solutions?
Now, the short-term solutions, as I said, if you really want to get something done now, you really need to have the rich countries start sharing doses now and not in 4 or 5 months' time when everybody in the US, the UK, or Europe is vaccinated. And we do call out to the rich countries. And we have found resonance, for example, the European Union at the summit recently, they embraced this. The second one is, and we were co-convening already in March, a roundtable looking at the bottlenecks, which are normal. The 10 billion COVID-19 vaccine mean you have a trebling of vaccine capacity overnight. Pre-COVID-19, the world produced 5 billion vaccines for all the diseases together, including seasonal flu. Now we need 10 billion for COVID-19 alone. It's normal, and when I talk to vaccine manufacturer CEOs, the big shortage and bottleneck is raw material right now. It's not capacity, it's not machinery. And the second big issue is trade barriers. We have all seen, Poonawalla shouting out at POTUS, please, stop blocking supply chains, stop using the Defense Production Act, do send us the ingredients which we need, because vaccine manufacturing is complex. To give you, an image, the Pfizer-BioNTech vaccine needs 280 ingredients from 86 suppliers coming from 19 different countries. And now Pfizer-BioNTech have done an amazing piece of work in scaling up manufacturing. Last November, they expected to be able to manufacture 1.3 billion doses. Now they talk about 2.5 billion as realistic, maybe even 3 billion this year, which basically would suffice for 30% of the world need. And we have seen similar scaling up, for example, from other manufacturers. But we do see challenges, for example, in the partnerships AstraZeneca has with the Serum Institute of India. I think I understand the domestic needs now, but we need to find, that's why I did mention these mRNA vaccines, we need to see a willingness from rich countries to start sharing. And I also believe that we could see efficiency gains if we do establish, for example, a matchmaking marketplace where companies who are in need, urgent need of giant plastic bags for the single-use bioreactors, for filters or RNA or other critical ingredients could deposit their needs. And there may be companies whose vaccine projects are delayed or failed, who may have actually a surplus. And that's something which honestly, WTO, COVAX, CEPI, Gavi, WHO, and us, together with our colleagues from the Developing Country Vaccine Manufacturer Network, I think we can really do an immediate contribution to tackling the crisis.
Right. Ellen, would you like to respond to Thomas's point that, there's been so much progress made so far and IP waivers are not really the issue that are standing in the way, but as he said, there are all these other concerns. where do you think that stands in the shortages that we see right now, and in really looking at solving this issue and really taking the manufacturing forward in the next 3 or 6 months to come?
Well, let me echo by what Thomas said, that we have seen an unprecedented sort of coming together of the world of science to bring these new vaccines to a reality. That has been absolutely phenomenal. And what you saw initially is what drove that was also the openness, the open science, and the sharing of the data, and the collaboration between scientists to develop these vaccines as rapidly as possible. That was really phenomenal. The other phenomenal element of that was the very significant investments and purchase commitments that were made by various governments. We should not underestimate the amounts of public financing that has gone into the development of these vaccines. That has been absolutely key to both support the scientists and the manufacturers that took up the role of producing and supplying these vaccines. That has been key. And I think in going forward, we need to keep that into focus, because that should not be a one-off thing. In the advocacy for sharing of that knowledge and the sharing of that intellectual property, and it will be no one's surprise that I will maintain the position that that will continue to be important when we move forward. Yes, there are 100,000 other things that need to be resolved, but we also need to have a global discussion about the sharing of the know-how and the knowledge that has been created with these enormous amounts of public financing. And as part of that discussion needs to be the continued demand and the continued pressure on the public sector to continue to financially support the development of vaccines and other tools that are necessary in pandemic response. The other area that we need to address is the fact that there are regions in the world where there is very little to no vaccine manufacturing capacity. Of course, you cannot ask to transfer technologies to areas where there is no one to receive it. But it does say something about how unprepared the world was for this pandemic, despite the fact that for decades, and Thomas will agree with me there, we've been at many World Health Assemblies together, and every year the Director General of the World Health Assembly says, please, make sure you're prepared because the big one is going to come. Well, here is the big one. And I think the first thing we have to conclude is the world was not prepared. And in moving forward and getting prepared also for the future, we need to address these issues of the financing of the innovation to make sure that that continues the way it happened in the last year, and the sharing of the knowledge that is then created. We also need investments in manufacturing capacity, because the world today has capacity for 3.5 billion doses, while 11 billion is needed to vaccinate 70% of the world population, which is sort of the level you need to get at. So for that, it is all hands on deck. And there is untapped manufacturing capacity that today is not used. There are manufacturers that have, without success, applied for licenses from corporations that hold the IP and have not gotten that. So that is something that also needs to be resolved. There needs to be a confidence in countries that may start to invest in manufacturing capacity and in donors that may be willing to contribute to that also in the future, that transfer of technology and that sharing of the intellectual property indeed will happen. And I hope that the discussions at the TRIPS Council will also, or that these proposals at the TRIPS Council and the upcoming World Health Assembly, or the World Health Assembly that's actually taking place as we speak, will address these issues. But I cannot stress the public financing that has contributed. Without that, we would not be where we are today. One other point where Thomas and I agree, I saw the headlines of 12-year-olds may be receiving the vaccine as of next week. And I think, what kind of world are we living in when health workers in Africa and India are not being vaccinated, and we're starting vaccinating 12-year-olds in North America. That is a completely disconnected world. And it doesn't matter whether you support the TRIPS waiver or not. If you let that happen, then the world really suffers from a complete breakdown in solidarity. And solidarity is what needs to underpin moving forward. The world needs to come together. This posturing and the conflicts that are breaking out at various levels and between countries and between companies, that really has to stop. We need to figure out a way to come together. And that doesn't always mean that we have to agree on every single point, but where are the areas where we can make progress? And sharing needs to be the theme of that game.
Thank you so much, Helen. I'm glad that between the differences, there are points that we agree on, and there are issues that we look forward to being resolved sort of, in a way that can prepare us not just for COVID-19, but for future pandemics to come. Thank you so much, Ellen. Thank you so much, Thomas, for your time. We look forward to covering this issue here at Devex. We look forward to discussing it more as the World Health Assembly goes on. Thank you, and thanks so much for your time.
Thank you very much.
Hello, everyone. Welcome back. Thank you for being with Devex at this World Health Assembly, this virtual World Health Assembly for us, coming to you from all over the world. I'm joined by my colleague, Amruta Byatnal in India. She's our Asia Pacific editor. Amruta, lots to unpack about what we've just seen. I think there was a lot of interest in the interview with the AstraZeneca CEO, Pascal Soriot. What stood out for you in that conversation with him?
That's right, Vince. I felt like it was a pretty insightful interview. And what was interesting to me was that he's acknowledging the fact that, AstraZeneca is not going to be able to fulfill all its commitments, mostly because of what is happening in India and the Serum Institute of India not being able to produce as much to export. And also the fact that he then said that, now it's upon richer countries to sort of donate vaccines to other countries in the world. And that was something that Thomas Cuny also said. So I felt like that was kind of an interesting sort of similarity between what the two men who are sort of at the center of this IP waiver vaccine debate have a similar solution to the problem.
It was fascinating indeed, and thank you for your role in these conversations and for your ongoing coverage of global health with Devex. I encourage those of you who aren't already subscribed to sign up to the checkup newsletter that Amruta helps put together with our colleague Jenny. Jenny is back with us tomorrow for some really interesting conversations as our coverage of the WHA continues, particularly on strengthening the WHO and this question of funding, sustainable financing. There's a really interesting panel where I believe Jenny is going to get into this question of whether the WHO should go to a replenishment model, as we would see with the Global Fund. And I think that's a fascinating question when we speak about how to make the most of this moment with COVID-19 to make some changes to WHO, which people have been complaining about for years, and the various recommendations that have come out of that. So stay with us tomorrow for that. Otherwise, all that remains to do is to thank our partners, AstraZeneca, Gilead, MOQ, the Novartis Foundation, GSK, and Save the Children. I will add that on Tuesday next week, we're having a kind of final wrap-up call on WHA with our reporters and with also Steve Davis from the Gates Foundation, which will be a chance for our pro subscribers to let us know what they're thinking as well. If you are not signed up as a Devex Pro subscriber yet, trials are free, so please do sign up before next Tuesday. And otherwise, I'll be here tomorrow and look forward to speaking to all of you then. See you all again tomorrow. Thank you.